Yeah, so we've had this debate about which PARP might be the best PARP, and there's been a lot of energy expended in this process. I think that most of us feel that the dominant mechanism of action for the PARP is probably covered equally in the specific agents. It would be very difficult to demonstrate with a reasonable sample size that there is any difference between these PARPs, based on what we've seen so far in both the treatment setting, the secondary switch maintenance setting, and the primary maintenance setting. So, so I don't think that's really where the value is. We do know that they have different side effect profiles, but we've gotten very comfortable in knowing how to mitigate that. I think we saw at ESMO this time around also the NORA trial, which was looking at a Chinese patient population, which are generally thinner, smaller people, where they did do the weights and plates kind of adjustments and showed that the individualized based dosing did mitigate a lot of the toxicity that we'd seen at the higher dose without really sacrificing any efficacy. So I think we're pretty comfortable with that, that kind of data. I think the real kind of value in the PARPs going forward is about who's going to show any benefit in what we call the HR proficient population. So the ones where the drugs should not work. And I think that's where most of our interest is, because we really have three kind of populations emerging. We have the patient population that who should have received a PARP inhibitor because they carried HRD, and they got it, and they either responded to it or they didn't progress for a while, but then they progressed. And so we've got this prior exposure, with a remote history, but have now progressed. And we got to decide whether or not those patients, could respond again. How do we best give it? That kind of thing. The other populations that we're seeing are the ones that we gave it to, and there's no doubt they were either intrinsically resistant or they developed resistance when they, while on treatment. So these are these mechanisms of resistance could be induced by other factors, and they could be different, but they have little chance of responding to just retreating with a PARP inhibitor. And then we've got the patients in whom we give a PARP to because it's indicated based on the approvals, but they were wild type, or they were HR proficient. And what we've seen is that the activity of a single agent PARP in that setting is relatively low. And so the concept is, can we turn that tumor into one that would be sensitive to a PARP? And all of those are looking at different kinds of ways to mitigate by adding something to. And so a lot of trials that we're looking at to try to sort that kind of question out so that we can make a good decision going forward. And we're hopeful that some of the trials that are being planned now will shed light on that, on those three things.